Welcome to Hema Now, the podcast that keeps you on the cutting edge of hematology. I'm your host, Dr. Jonathan Sackyer, and today we have the privilege of speaking with Dr. Xavier Leleu, a world-renowned expert in multiple myeloma, lymphoplasmacytic lymphoma, and amyloidosis. Dr. Leleu has an impressive academic background, including a PhD from the Dana-Farber Cancer Institute in Boston. He regularly contributes to international clinical trials and speaks at major medical congresses. Today, he'll be sharing his insights into the latest advances in the biology and treatment of multiple myeloma. So let's dive right in and welcome Dr. Xavier Leleu. It's a pleasure to have him on the podcast. So, Dr. Xavier Leleu, lovely to be with you.
Lovely to be with you as well.
Fantastic. So let's dig in. Your phase 3 trial, and I'm going to apologize. I have a mental block on an ability to say any drug name ending with MAB. I'm just a simple surgeon. But your phase 3 trial on isatuximab with bortezomib, lenalidomide, and dexamethasone showed a remarkable increase in minimal residual disease negativity rates exceeding 50%. How significant is this? And could it redefine standard treatment for transplant-ineligible myeloma patients?
Thank you. You're absolutely right. It's very, very significant. So point number one, the reference treatment, what we call the control arm in clinical trials, the treatment that most of the patients receive in the world, being transplant ineligible, is these days limited to two types of regimens. Either you have a 100% immunological based regimen type CD38 monoclonal antibody, daratumumab, lenalidomide, dexamethasone, or you have a treatment based on the proteasome inhibitors type bortezomib, for example, Velcade, plus lenalidomide and dexamethasone. In the two regimens, the most impacting data we've been able to collect are, in terms of PFS, for VRD, the best median PFS was approximately 44 months. For Dara-Lendex, the best median PFS was the data from Maya, the most recent, the most important, the best one we've had before, and it was a median PFS at 62 months. The best MD negativity rate at 10 to minus 5 we've been able to obtain was no better than 30%. And as soon as we start digging a little bit and being more into something like fixed MD analysis, sustained MD analysis, prolonged MD negativity rates, it was less than 15%. So when you add one drug to a triplet becoming a quadruplet, and you jump from 15 best 30% to 50%, it's truly a gigantic increase in MD negativity rate in that type of patients.
Well, obviously, with wonderful implications for the patients, good news. And MRD's become a key endpoint in myeloma trials, to my understanding. How do you see MRD testing influencing treatment decisions? Could it help redefine strategies for relapsed and refractory patients?
Absolutely. This is absolutely a key question. If we want MD analysis not to be just for clinical trials, but to be used in real practice, it has to change the practice of the patient. It has to be a test that the physician can use to adapt the treatment of the patients, or either to tailor ahead of starting the treatment or to adapt the treatment of patients. And it is not yet ready for prime time in real life because we don't have yet the answer to a certain number of clinical trials ongoing, clinical trials where the key question is, if you maintain an MD negative status, great situation. Can you treat less, or should you treat the same way? And if you are not MD negative, so if you seems to have a lesser, not as good condition, should you be treated more, or should you maintain on the same treatment? So there are a lot of clinical trials ongoing. We don't know yet the answer to this question, but we agree that MD will make sense in the real life if it can be more than just a prognostic marker, but also a drug, a treatment adaptive marker. It's to come. We have to be patient a little bit more.
Okay, so given these data point and the work that you've done, it highlights the declining prognosis of myeloma patients with each additional line of therapy. I don't think that's uncommon in any malignant disease. Given the need for effective later line treatments, should we be rethinking therapeutic strategies and where we roll out each treatment for these patients?
Well, this is also a great question, and it has been a question that we have asked and asked again and asked again. Each time we combine more upfront, each time we improve the upfront treatment by putting more treatments in the upfront setting, we know we are taking out these treatments from the relapse setting. And so if we improve line one, but we deteriorate the subsequent line, overall, the overalls of the patient, the overall survival of the patient might not be as good as we want to. And again, it's a key question. So what we have demonstrated years after years, treatment after treatment, new regimen after new regimen, is that there's always a benefit by giving the base drugs, even altogether upfront, than waiting for the subsequent lines for various reasons. Number one, the more you relapse, the more your myeloma becomes not as nice as it used to be. Uh, Number two, 20 to 40% of the patient will die in between the lines. And by not giving the base drug initially, will never get the drugs later on because sadly, something very terrible will happen and this patient might die in between the lines. Number three, the treatments are less effective in subsequent line that upfront line. The same regimen, for example, daratumumab, lenalidomide, dexamethasone, in the relapse setting, line 2 or 3, provided the median PFS around 40 months. When it was upfront, the median PFS was around 62 months. It's the same treatment. So there are so many reasons to believe, to demonstrate, and there has been so many studies demonstrating that best regimen, best combination should be used up front, even if it means that we exhaust the treatment for relapse setting. Now, once I've said that, because many patients do relapse despite this impressive treatment up front, it is our responsibility to make sure that we keep developing drugs in the relapse setting for these patients. And that's exactly what we do.
Yeah. So, an argument that I've seen made is also from, sadly, one always has to consider economics. And the drugs that you guys use are not inexpensive. People say, "Oh, well, this is a very expensive drug. We can't possibly fund this." But if you look at the cost to treat the patient from diagnosis to demise, it often makes sense to use the more expensive medication up front because you get the better effect and you minimize their exposure to the healthcare system. You actually save more money and you can treat more patients. Does that hold true?
Yes and no. So you're absolutely right. If you prolong the survival upfront when the patients are best responsive, safer overall, um, in in the end, the utilization of the healthcare system is lesser. So it is pharmacoeconomically very sound. I agree to that. One limitation to this way of thinking is that the treatment we give today are treatment forever. We don't know how to stop the treatment. We don't know. Myeloma is never cured, so we don't know when for whom, for which patient we could stop the treatment and still the disease will not relapse. So if you put all your treatment most effective up front and you have a median PFS of maybe, I don't know, 15 years, 20 years, you're going to treat the patient for 15 years, 20 years. The people that works in the healthcare system economics are going to say, but that's going to cost hell. So I want to temper a little bit the message here, but clearly the best drug up front will benefit most for the patients, and when you benefit most for the patients, then it's better for the healthcare system. Now, once I've said that, my regimen, isatuximab, bortezomib, dexamethasone, is the best pharmacoeconomically best treatment out there because you have 4 drugs, but 3 of them are generic and only one drug is, in a certain extent, costly. And it's not outrageously costly, although we could discuss when it comes to 5,000, 10,000, 12,000, 15,000 euros, it's probably outrageous for many countries. But there's only one drug out of four that is expensive. The other three drugs are generic. And it's in the end, for what it gives in terms of efficacy, it's probably a very interesting pharmacoeconomical regimen in the end. But again, I'm not an expert in that field, so I'm being careful what I'm saying here.
Okay, well, it's interesting. Thank you very much for that perspective. I think it always makes the point that this stuff is very complicated, and paying for stuff is very complicated when you've got human beings at the end of it who've got lives and families and all the rest of it. So, moving on, you've spoken about the challenge of maintaining effective therapies in later line myeloma. Why do you think drugs move to frontline treatment so quickly, and do you see potential for dedicated therapies in this setting?
Again, of course, great question. For many reasons. Number one, um, 99% of the drug we develop now are immunotherapy based or immunotherapy drugs. Um, and immunotherapy drugs always works better initially when the immune system has not been compromised, has not been exhausted, has not been put under too much pressure for too long or just too much pressure. So uh, it makes sense when you use immunotherapy based regimens to use them rather earlier than later. Point number one. Point number two, uh, when you see how effective is a drug in the relapse setting, you of course immediately want to use it upfront because you know that if you move that drug to upfront, the benefit will be multiplied by X% improvement, and we it's very much what we see. A drug could be effective in the relapse setting, and when you use it upfront, it is twice as better, or maybe three times, five times, 10 times better when you use it up front. So naturally, when you see a drug that is revolutionary in the relapse setting, you it makes sense to uh, to help the company develop these drugs up front. Number three, immunotherapy have side effects. They always, all drugs have side effects. When a drug works in cancer, it has side effects. A drug with zero side effects, you can question activity. I wish one day we could say, you know what, we have found the first ever drug developed that is zero side effects but 100% activity. I wish we would say that to a patient, but I don't think this is true today. And so, if you want to mitigate, to minimize, to limit maximum the safety profile, the safety issues to patients, it's always better to use the drugs when the patient is younger, fitter, upfront at diagnosis. So there are many reasons to explain why we in myeloma we have been very good at developing drug in the end stage, but very good at developing them upfront, even though it means that then the drugs are not available anymore in the relapse setting.
Yeah, yeah, interesting. Your comment about biological activity it is key. And I remember someone once saying to me they were at an investment conference, and he said, "Next year I'm going to invest in a drug called placebo. It seems to be amazing." But then, of course, there's also the nocebo effect. So last year, you were a joint author of a paper from the International Myeloma Working Group Immunotherapy Committee that addressed consensus guidelines and recommendations for optimal use of T-cell engaging biospecific antibodies in multiple myeloma. Talk to us a little bit about those guidelines, please.
The two immunotherapy concept, drug, type of treatment have been developed recently in general in cancer, but particularly in myeloma. And immediately we found out that these two concepts are really truly incredible. Not only because biologically it's so exciting, it's so genius, but also because when we look at the activity on the patients, it's just groundbreaking. We've never seen that before. So the two type of immunotherapy I'm talking about here are the bispecific, the T cell engagers that you spoke about, and the CAR T cell concept. But here we're going to focus on the bispecific, the T cell engagers. So again, there's no free lunch, as the US like to say. When you use a T cell engager, you're going to create something which is incredibly effective on tumor cells. You're going to recreate that immune synapse. the T cells in patients that with myeloma, the T cells are completely blind. They are next to the tumor cells, but they are not effective. They are not doing anything. They are not killing that tumor cell. With the bispecific, the T cells are going to be maintained next to the tumor cells and they are going to be able again to kill the tumor cells. One great thing here is that now your tumor cells naturally are going to destroy your cancer, and this is great. One immediate limitation that we can immediately understand from that mechanism of action is that if the T cells are systematically killing the tumor cell, but who's taking care of the rest of the body? In case of an infection, who's in charge of the infections? Well, no one. So one of the limitation of the bispecific is that they are such good drugs, such amazing drugs that we rapidly understood we face two issues. Number one, there is no break. When the T cells start killing the tumor cells, they kill the tumor cells and they kill the tumor cells until there's no more tumor cells. And that could create a little bit of dysfunction in the body of the patients, and we have to manage that. This is what we call the CRS, cytokine release syndrome, number one. Number two, when we give T cells, we know that if we inject T cells, they're going to focus immediately on the tumor cells. And if there's an infection to manage in parallel, they won't be available to manage that infection. They won't be physically fit to and ready to manage this infection. And so there was a need to allow the use of the T-cell engager bispecific, particularly the BCMA-CD3 targeting. There was a need to make sure that if we want to recommend the use of that drugs in any center in the world, academic, community, private practice, physician treating 2 patients a month, or physician like me treating 200 patients a week, everyone could be using these gigantic drugs, these revolutionary drugs. And the only way to help the physician manage the CRS and the infection issues was to make sure that altogether the experts, we could find out the easiest way to make these drugs available for the security and the safety of the patients and their families. And that's the principle of these guidelines.
The guidance. Well, thank you very much for that. So we've talked a lot about multiple myeloma, but your expertise extends beyond that to lymphoplasmacytic lymphoma, amyloidosis. You, you shrug. I, what I know about these subjects could be written on the head of a very, very small pin. So, what are some of the latest, most exciting advances in these areas, and are there any overlaps in therapeutic approaches with multiple myeloma?
Well, I have to admit that my 100% focus now is myeloma and amyloidosis, AL amyloidosis, primary amyloidosis related to light chain immunoglobulin, and lymphoplasmacytoma, so-called Waldenström disease, is not anymore a disease I can work too much on and focus on for sake of time and for need to focus. But once I've said that, the lymphoplasmacytoma Waldenström disease is very, very different from amyloidosis and very, very different from myeloma. Lymphocytoma has become lymphoplasmacytoma and lymphoma slash Waldenström disease has become a low-grade B-cell lymphoma. And it is treated now as a low-grade B-cell lymphoma with some specificities. And it's truly to the expert in low-grade B-cell lymphoma that you should be asking the question, not me. But in the past, we have been using a lot of the myeloma drug into the Waldenström, but it's not anymore. Now they are using specific drugs that they know are very effective in low-grade B-cell lymphoma to two patients with Waldenström. So honestly, there is no much connection into the two fields, the two words, the myeloma amyloidosis and the lymphoplasmacytic lymphoma Waldenström. Now, for amyloidosis, it's a different story. For amyloidosis, AL amyloidosis, again, only AL amyloidosis. But for primary AL amyloidosis, primitive AL amyloidosis, yes, the drug, because it's very close to myeloma, the drug that works in myeloma have always been working very, very well in a primary AL amyloidosis. With two interesting things is that amyloidosis is a much better prognosis than myeloma, technically speaking. However, because of the organ malfunction because of the organ attacks. Patient could have a poor prognosis because of the organ involvements, not because of the cancer itself. But the treatment that works in myeloma have always been very effective in amyloidosis, with globally two types of patients: the patients that have really end-stage organ disease, particularly cardiac. For these patients, it remains difficult because to get rid of the deposit in the organ takes years, and and so for many patients, it's too late to really change the story of the disease and the prognosis of the patient, given the organ damage. But for many, many patients now with amyloidosis, the good prognosis is really what we see with the patients, because the drugs like T-cell engager, the CD38 monoclonal antibodies, the daratumumab, isatuximab, the MAB drugs, as you said you were not too happy pronouncing, and even the bortezomib, the proteasome inhibitors, the combination of these drugs almost, I mean, there's no cure, but you almost at the verge of being able to say to a patient, you might get cured, actually, because maybe we stop the production of new light chains, so we stop the deposit. With time, the already deposited light chains will get cleaned by the macrophage, etc. And maybe if you don't relapse in the next 10 to 15 years, maybe you're good out without any issue anymore.
Yeah, it's fascinating. So, looking ahead, going back to multiple myeloma, do you think the future of treatment here will continue to involve CD38 targeted immunotherapies like the unpronounceable MAB drugs, or do you foresee it's just a mental block for me? I don't know what it is. I mean, I can say lymphoplasmacytic, but I can't say the MAB drugs. Do you foresee a shift towards new treatment modalities? You've already mentioned CAR T or biospecific antibodies.
Well, I see well, everything is going to exist. First of all, multiple myeloma is not multiple for no reason. We said multiple myeloma because we have not been able, contrary to the lymphoma field, to already say, okay, you have a multiple myeloma 1114, a multiple myeloma X, a multiple myeloma Z. We do not have yet that separation in groups clearly identify with different treatments. We do not have that yet in myeloma, and we might get there at some point. But still, despite myeloma is multiple, so there will be patients with CAR approach upfront. There will be patients with T-cell engagers, single agent monotherapy approach upfront. But there will be patients that will need a T-cell engager in combination. And there will be patients where one of the drug in combination might be one hand the T-cell engager, and on the other hand the CD38 MAB monoclonal antibody in combination. And you will have patients that cannot receive a CAR, cannot receive a T-cell engager, and might be treated with microduped regimen that logically should be updated in 5 years. But for some patients, might remain an excellent approach, safe enough, not too complex, cheap enough by then, because by then 4 drugs will be then generic. And so I don't think there will never be one treatment for all patients in myeloma. And the more and more, it's going to be very, very much tailored. But it's fair to say that the T-cell engager, BCMA CD3, and the CAR T, particularly the BCMA, might take over a great part of the first-line upfront treatment regimen options to great number of patients, and probably the fittest one.
You're so deep into it. When I prepare for conversations such as this, I reflect back on my time at medical school and how Waldenström's macroglobulinemia, as it was then known, how the treatment options for these diseases have changed dramatically. So thank you to you and your profession for what you've done for these patients. You've mentioned that you'd like to see a drug one day that worked in everyone 100% and had no side effects. That's a great wish. Let's assume you've got 3 wishes for your area of healthcare. What would they be, Javier?
Uh, So wish as a so okay, I'm gonna answer your question. Okay, there are various ways to answer your question, but I'm gonna give you one. So number one, I'm gonna make a wish for the patient. I'm gonna make a wish for the physician, and I'm gonna make a wish for the society in general. It's not necessarily my three wishes as my three wish, but I think it's fair enough wishes to satisfy everyone. What the patient wants is to get cured, but not necessarily cured, meaning I don't have any cancer anymore. What the patient wants is that they get treated, and at some point they stop the treatment. And they know that maybe the disease will relapse, but in their vision of their future, in a different future. If I relapse in 10 years, it's a different disease. Even though it's the same disease, it, it's a different cancer. It's a different approach. So, and for certain patients, it's 30 years. For certain patients, might be 10 years. So, number one, the wish for the patient is to identify a treatment that could be given to patient, control the disease so massively that after 1 or 2 years of treatment, I could definitely stop the treatment, but the patient will not relapse earlier because I have stopped the treatment. And a treatment where the patient could relapse in 10 years, 15 years, 20 years, and to the point that for them, when they relapse, it's a different cancer. And because patients 70 years old accept that today they have a cancer, they might have no disease for 10 or 15 years, and in 10 and 50 years, they might have different disease because they're older. Point number one. Point number two, as a physician, I wish we could be very driving the treatment of the patient very much based on biology, on what the disease is about, and not anymore based on pharmacoeconomic concerns, what drug I have access in my country, uh, whether my center can treat or not treat patient because I got accreditation or because I'm experienced or because. So I wish I would truly treat the patient for what the patient needs and not anymore according to a number of constraints that are not helping truly in the treatment of patients. And I would go as far as sometimes even makes no sense, are the opposite of what we should be giving the patients. Number three, for the society, the wish for the society is that the treatment must make sense. And in that regard, I think what has been done in the UK, what the NICE has done in the UK, even though initially everyone was looking at it as these guys are crazy, in the end, everyone is getting there. In the end, everyone is saying that the vision of the NICE is a bit too much, a bit too caricatural, but the fact that a treatment for a patient must make sense to the society is important. In France, it is in our culture to treat everyone all the time, never stop. Even giving 12,000 euros to a patient that might die in 2 months, does it make sense? I don't know. I don't want to answer to that question, but I think we should be asking the question. It's not because I don't want to answer to the question that we should not be asking the question. So I think something that is cultural in UK that is not in France, and it should become in France cultural, maybe not to the same extent as where the UK have went, but something we should find is something in the middle, is that if I treat a patient with expensive drug, it must have a sense not for only for the patient, but also for the community. And this notion that it should be financially sustainable, whatever the definition, is something we should always have at mind. And we physicians, have tools, indicators, markers, help to better define this and to better explain that to the patients and to our teams, to the people we work with. And today in my job, it's missing, at least in my country, in France. I don't know if I was very explicative too much of my wishes, but at least this would help better treat the patient, definitely in the end.
I love that perspective because when you put them all together at the center of it all, we exist as physicians for the patients. The healthcare system exists for the patients, not for the administrators or the politicians. Countries, societies do have to make decisions on where they spend the taxpayers' money. Um, And I agree with your perspectives, but wouldn't it be lovely to have a world where we didn't have to think about deploying money for, unpleasant things like defense, and we could spend more on healthcare. I want to thank you. I've already thanked you for what you and your profession have done. I have loved ones who've dealt with multiple myeloma and other hematologic malignancy. So I've witnessed it firsthand, the wonderful things you can do. Also, the wonderful thing you did by taking time out of your busy day to chat with me for a short while. So, Dr. Xavier Leleu, thank you so much for joining us. It's been a real pleasure chatting with you.
Thank you very much for inviting me, and talk to you soon with more things coming.
Well, I hope you enjoyed that episode of Hema Now, our bi-weekly podcast on hematology. Please consider subscribing on either Apple Podcasts or Spotify, or frankly, wherever you get your podcasts, so that you never miss an episode. Like us on social media, tell your friends and colleagues, and please check out the archives because they're growing if you've missed any episodes. And please join us again in 2 weeks for another episode. Until then, I'm Dr. Jonathan Sackey. I'm proud to be your host. Please, everyone, stay safe, stay well, stay curious. Bye for now.